Welcome to the Endocrine and Hormone Dysfunction Module Preview. This is a module preview as part of the Optional Aging Academy. Today we're going to be talking about why hormone function depends on signaling, not just the numbers. My name is Dr. Sajad Zalzala, and I'll be your guide for today. Next slide. So before we begin, I want to talk to you a little bit about myself. Again, people call me Dr. Z. For the past 2 decades, I've been interested in functional medicine and longevity, and translating complex aging science into practical, measurable clinical systems that can help people slow the aging process and make aging optional. I'm the co-founder of AgeSRX. It was the first telehealth company dedicated to longevity, and I've led or co-authored multiple peer-reviewed research papers in aging, rapamycin, LDN, healthspan. And I've been an advisor to multiple digital health and diagnostic companies. Most importantly, the framework that you see today is reflection of years of clinical pattern recognition and not just theory alone. Before we begin, let's talk about what we're going to cover in this mini masterclass, this module preview. First of all, why hormone levels does not always equal hormone function. Normal labs don't always guarantee effective signaling or optimal signaling. We're going to be talking about the biological hormone tracks, so the difference between men, and then the 2 types of tracks for the women. And then we'll be talking a little bit about the hormone resistance syndromes and a little bit about why they occur and why it's important to address them. And then we talk about from replacement to optimization. And of course, we'll have some cases in there as well to help highlight, and we'll talk about the archetypes as well. All right. First, let's talk a little bit about why hormones fail in modern life. Hormones seem to be a bigger and bigger issue. We have more men than ever on testosterone replacement. We have more women than ever seem to have imbalance of their estrogen and progesterone. Why is that? There's multiple different reasons, as you can see on this this infographic here. Part of it is at the top, you'll see the high inflammatory signal, low signal fidelity. This has to do a little bit with the resistance we talked about, the high metabolic burden, and then the low central regulation. So you can see, there's a lot of things that kind of stack up in modern life to cause us to have so many issues with our signaling, which is hormones. By the way, the full module will talk more than just the sex hormones. There will be information about cortisol as well as thyroid. We're not going to be talking about those today in the module preview, but they will be addressed in the full module. So actually, this slide talks a little bit about insulin resistance. Insulin resistance is very common. It's thought that anybody who struggles with weight has insulin resistance, and of course, taken to the extreme, it can lead to type 2 diabetes. But there's also lesser known thyroid resistance, cortisol resistance, and pretty much anywhere where you have a molecule, a messenger molecule like a hormone that docks with a receptor, you can have a receptor that's potentially non-responsive, which is given the general term resistance. And that's what resistance means, is that you can have 2 people have the same exact amount of hormone, but one person receptors are listening and tuned, and responds really well, and the other one doesn't respond at all. The example that all doctors and everybody in the medical field can relate to is insulin resistance. Injecting insulin is still very common. It's less common now that we have the GLP-1 medications, but that's a different story. Doctors would commonly see diabetic patients. 2 patients have the same exact glucose numbers. One patient requires 10 units of insulin to bring their numbers down. The other one requires 100 units of insulin. It's the same exact insulin, 2 different people, 2 different systems, 2 different resistance amounts. And that can happen across pretty much, like I said, pretty much all of them. The science on the resistance syndromes for things like thyroid and sex hormones is not as well established, but I believe it's real. And I've seen it in clinical practice. I've seen patients on ungodly amounts of thyroid medication, and they still have symptoms, and their labs barely look normal. So it's definitely something. It's just not as well recognized as insulin resistance. But hopefully you understand the concept, and we'll talk about more about what to do with that in the full module. When you go to like a longevity clinic or you listen to a longevity talk, a lot of it focuses on replacement. And I have no problem with the replacement. I think replacement is great for the right person at the right time. But I prefer to use the terminology optimization rather than replacement. So hormone optimization trumps replacement. Of course, sometimes you need to do replacement in order to optimize, but not replacement just for the sake of replacement, if you know what I mean. So again, because you have hormone response, different people, different responses. You could have two people on the same dose. We already talked about that. Intervention intensity, biological tract, whether it's adult male, cycling women, non-cycling women, and of course, what's the terrain like? What's the context like? Inflammation, stress, all these things can help determine optimization status for hormones. All right, so before we jump into the archetypes, let's talk a little bit about the biological tract framework. This is a little bit different than the other modules. The other modules tend to be more, sex agnostic, but in this case, it would be foolish not to break this up. So, one tract is adult men, and adult men tend to have, we don't cycle through our testosterone typically, not much, not nearly as much as women cycle through estrogen, progesterone. So that's why it's considered to be relatively stable. It declines gradually over time. There's no andropause. Some people have described an andropause, but there's no natural andropause. If andropause happens in men, it's abnormal. For women, again, we want to differentiate between the cycling female, who's still in their reproductive years, versus a postmenopausal female, because there are different approaches. And we'll talk a little bit more. We'll talk much more about that in the full module, and a little bit more about that here in this module preview as well. All right, so again, the archetypes, key to help us to understand how to approach the different interventions with different individual students. So the 4 archetypes here for men, you can have the low T, high stress, what's called the high stress burner. You can have the metabolic low drive archetype. You can have the high estrogen, low testosterone aromatizer archetype. And then you can have multi-axis decline. They have a little bit of everything. So you can see on the slide, the different patterns. Like, for example, the low T, high stress would be, having a hard time recovering, poor training response, low libido. Whereas somebody with the high estrogen, they're unlike the low testosterone person. This type of man would typically have normal testosterone, but it feels low for them. They may not be as well built. They may not be able to gain as much muscle, and they could have some emotional sensitivity that's unusual for uncharacteristic for that man. And then you have multi-axis, a little bit of everything, like I said. All right, the next set of archetypes has to do with the cycling women. Again, defined as women who still are of the age where they're cycling. There's of course some exceptions for women who underwent premature menopause or surgical menopause prematurely. Those are a little bit edge cases. We're not going to be talking about those today. We'll talk a little bit about them in the full module. But again, these courses should be for everybody, so we can't spend too much time on edge cases. But with the archetypes for the cycling women, you have estrogen dominant, you have the low progesterone luteal phase, women who crash during that phase. You have the low androgen, low vitality, and then you have the multi-axis perimenopausal. And then you also have women who have excess androgens as well. That's, I believe, in one of these archetypes. Typically the low progesterone luteal phase crasher. Postmenopausal typically tends to be a little more straightforward because women have almost a zero baseline for estrogen progesterone. Not zero exactly, but near zero. Their ovaries, has ceased production. They have a little bit of estrogen made from the fat cells and adrenals and things like that, but it's negligible compared to what the ovaries used to make. So in some ways, it's a little bit more straightforward than cycling women. But we can also break them down into archetypes. The neurovascular hormone deficiency archetype, the low androgen, low drive, and then the archetype where there's a lot of intersection between thyroid and adrenal, and of course the multi-axis, a little bit of everything. All right, and then these tracks and these archetypes help to explain why labs can mean different things across different biological tracks. I mean, obviously, men are known to have high levels of testosterone. Women actually have testosterone as well, and it's as an absolute value, it's actually higher than their estrogen levels. But it's nowhere near as high as the typical man is. Of course, you do have there's always exception. That's why I say typical. And again, for cycling women, for example, pinpointing the labs can be very difficult. Because then you have to time it right and things like that. And even then, I mean, timing it right kind of means that the woman actually has to have predictable cycle. But chances are, if that person is going for blood tests for hormones, they probably don't have predictable cycles, which is a problem that they're seeking help for. So that's why, in some cases, lab work dominates. In other cases, symptoms dominate. But again, that's why we kind of need both together. And we'll talk about that a little bit here in a minute. Of course, everybody knows somebody who's like, they're on some kind of therapy, or they have what they think is a hormonal issue or imbalance, and they go and they do blood work, and it turns out to be normal according to the conventional. And again, we talked about this before. You could have insensitivity at the receptor level. You could have other things going on. Like I see this a lot with thyroid patients, for example. Their thyroid, on paper looks fine, but they have almost all the symptoms, like their symptoms haven't resolved. And unfortunately, it's not as easy as putting more thyroid on you. There are other reasons for the symptoms as well. Some of them we cover in the course, and some of them are kind of beyond the course. Things like mast cell disorder and whatnot. Some of the more, Lyme disease. Those are kind of beyond the course, because those go more into disease states rather than the drivers or the biological drivers of aging. And then this also helps explain why replacement alone often fails. When replacement is initiated, I usually see guys, for example, they get started on testosterone shots and they feel great initially, then usually fade quickly because they haven't addressed the underlying cause. And also the other reasons people reach a new baseline, they feel better, but now they forget how lousy they may have felt, and so their newer baseline becomes a new baseline. So a little bit of psychological, and that's kind of just the human. It's not something bad necessarily. It's just kind of a human condition. We're always looking for better. It's just the way we're built. But at some point, I teach this in one of the modules in terms of trying to be content with where you're at, but always striving for improvement at the same time. And going back to why replacement often fails is, we typically see dose escalation, for the thyroid patient, they may get partial symptom relief, want more. Unfortunately, the reality sometimes is no amount of thyroid in the world is going to cause complete symptom remission for these patients, or return to no symptoms for some patients. And again, that's why it's important to treat aging like a framework, holistically, not just in isolation. It's not just your thyroid, it's not just your testosterone, it's not necessarily just your estrogen. And then replacement without preparation often can amplify dysfunction or uncover other dysfunction you didn't really consider. So what does it mean to actually optimize hormones? It means an improvement in signal quality, returning kind of the physiological balance that we see in somebody who's thought to be perfectly healthy, if there is such a thing anymore. You can always strive for perfection and optimization. And then, more is not always better. Sometimes, understanding the framework leads to more effective treatment, not higher dose treatment. And then also understanding long-term safety. Anytime you intervene, there are some therapies that are thought to be benign, and, you can, take a lot of it without any problems, and other therapies are less benign. And so you don't necessarily want to overdo any given therapy. So I'm always going to focus on long-term safety, because what's the point of starting a therapy or going on an intervention and then you're sabotaging your long-term safety? I mean, it doesn't make sense. So that's why, again, during the full module, we'll talk a lot about that. Again, we've already talked about this, so I'm going to go through this quickly. We're looking for signals, not just numbers. That's why we take the subjective data, how are you feeling, what your function is, et cetera, for those 3 tracks that we talked about. And then we also look at the objective data. Typically, this will be things like testosterone, estrogen, prolactin, things like that. And we look at that assessment as a whole. For some people, the subjective may be all they're able to do. That's a good start to get you going. I can give you a lot of the clues that you're looking for, but in this particular, there are some modules that are more needy of or necessitate the objective markers. I would say the hormone module is one of those modules where you almost need the objective. You can't just necessarily go based on subjective alone, but you can't just go based on the objective either, like we talked about. So it does need to be one of those things where you have to put the two together. So when we're talking about objective hormone assessment, again, lab value provide critical details, trackable over time. You want to make sure you don't overdo anything. And then, there are different optimal ranges you want to find yourself in. There's usually not one number that fits everybody, and that's why there's typically ranges. And some people could do really well at the bottom end of the optimal range. Some people need to be at the upper end of optimal range. So that's why typically a rate, that's how biology is. It operates within range tolerances. So we'll talk more about that in the full course. Of course, the limitations is, it ignores timing, tissue response. It ignores, the subjective aspect of it, whether or not the hormone's actually doing its job as intended, or whether or not the hormone's even the problem to begin with. Subjective, we look at things like energy recovery, libido, sleep, motivation, mood, stress, cognition. Symptoms are not just noise, they're not just in your head, they're data. We talked about this already, why optimization requires both, because typically dysfunction hides in the gaps. If you look at just the subjective, you're missing stuff. If you look at just the objective, you're missing stuff. Subjective symptoms typically show up before before you see the biomarkers, and this is why a lot of people, they do biomarkers and everything seems normal. Sometimes the subjective response is an early warning, and you want to take that seriously and kind of pursue those as well. But the objective data can be a guide along with the subjective data. It provides this holistic insight to take the both into account. And then optimization happens where the patterns emerge from data and experience, and then you do the reassessment. All right, what does the assessment look like in men? For the objective, we look at the various different hormone levels. Again, we detail this in the full course. And then for the subjective, we look at energy, libido, mood, recovery, and these often reflect systemic issues. Whether there's inflammatory problems, issues with hormone signaling. In men, labs tell us what's happening. Symptoms kind of explain why. So for men, it's you both are they're almost equally weighted in some ways for the adult men population. Cycling women, we talked about this. We touched on this a little bit earlier. Labs are actually a lot trickier because they fluctuate so much throughout the cycle. It's really hard to pin down specific things like estrogen, progesterone. Even things like LH, FSH can fluctuate over time, making them a lot harder to go based off of. And this is one of the limitations with lab work. So for cycling women, actually the assessment, the subjective assessment is a lot more important than the objective one. Again, the objective one is there just to rule out any major issues and also make sure any interventions that are done are not overdone or underdone. You want the balance. But in this case, because of the limitations of blood work, the subjective tends to take priority. For postmenopausal, it's subjective is also important, but in this case, the objective is more important because we want to make sure we stay within a safe range, and helps guide dosing and things like that. And sometimes the subjective can be a little bit deceiving, like I mentioned before. We may get a postmenopausal woman in the right optimal ranges, but maybe they don't feel as well as they want to. That's kind of where we have to look at other things: the sleep, the inflammation, the other drivers that we talked about. So it doesn't necessarily mean that the hormones are not doing their job, but that could be an indication that there's other things going on. So for postmenopausal women, actually the lab tests tend to guide us a little bit more than the subjective. How do we integrate it? We talked about this already. We don't look at one lab test in isolation unless there's an obvious discrepancy or something's completely off, although sometimes there could be lab errors. And then we integrate the two together, and that helps us come up, better solidify the bottlenecks and the archetypes. It's not just about chasing numbers, it's about recognizing the pattern and responding as intelligently as possible. So the archetypes is the framework. In the full module, we'll talk about why hormones are treated differently in different people, and then the 3 tracks. So here's some cases that help kind of highlight the what to expect in the full module as you kind of go through this yourself. So here's an adult male, 44-year-old male, BMI is around 29, gaining some weight centrally, sedentary job, sleep is so-so. No formal metabolic diagnosis. A lot of times, patients like this will go to their doctor and will be told, their sugar is normal, their the blood work is essentially normal, nothing to worry about. But this person has low energy, motivation, libido. So what does the data show? Low normal testosterone, maybe borderline low free testosterone. You might see some elevation of the SHBG, but not always. Maybe some elevation of estradiol because the central fat is aromatizing it. But kind of the key things here will be you'll see typically an elevated fasting insulin, and either a normal or a borderline high normal A1C level in this person. Then they'll have post-meal fatigue. If they do try to exercise, they won't get the gains that they're looking for, and then they have a decline in their libido and energy levels, hence the fatigue. So the pattern identification here, again, this is the metabolic low drive pattern with the dominant archetype, usually led by inflammation, insulin resistance, stress, poor eating, not being physical active. The body's doing trying to do its job to keep everything in homeostasis, which is why the labs look kind of normal or maybe just borderline, so not like completely off, which is why it can be disappointing. But with the right interventions, then we can get a patient like this back or a student like this back on track. So we talked a little bit about it. So the interventions will look at restoring insulin resistance, improving sleep, lowering the inflammation burden, and then reassessing to see, okay, does this person need to be on some kind of support for testosterone, to boost their testosterone a little bit. Only at that point then we would think about giving some support to boost testosterone. Case number 2. So here's a cycling female patient, in their late 30s. They're cycling regular, but not as regular as it used to be. They're having PMS symptoms and mood swings. Their sleep is usually okay, except for before their periods, which kind of goes along with the PMS, and they're having some issues with anxiety, irritability, and they're just not tolerating stress like they used to. Again, they go to, may go to a conventional doctor, may have some blood work done, and because the labs fluctuate so much, a lot of times doctors are not quite sure what to do with these, other than put them on birth control, which is a whole other set of problems altogether. I'm not against birth control, but I'm not a big fan either. So here's the data. Typically, these types of patients will have, maybe mid to high normal estrogen. They tend to be a little bit estrogen dominant. Progesterone tends to be a little bit on the low side. Maybe the DHEA, they're kind of burning it off with their stress. And they might have like a low, maybe even normal testosterone. And, sometimes these women hope that it's the thyroid because, they think it's an easy fix, but not always. It's not always a thyroid. All right, so the pattern that we've identified here, the archetype is a low progesterone luteal phase crasher, inadequate progesterone signaling, usually driven by factors that are leading to too much stress. Kind of hinted this where you're kind of stealing the DHEA and the progesterone away, and so causing a relative deficiency. So what we do for this sort of thing, we want to restore progesterone signaling, try to figure out what to do to reduce stress factors, help stabilize sleep and recovery. So a lot of that will be taught in the full module. All right, on to case 3. Postmenopausal woman in the mid-50s, been postmenopausal for a couple of years now. BMI seems okay, but they're having things like hot flashes, poor sleep, brain fog. She's, a lot of patients in her situation, a lot of students in her situation are adapting to the situation, but just feels like something's off, and they don't really want to settle. They feel like they're settling by having these symptoms. So what does the data show? Of course, postmenopausal, like I mentioned before, almost all the hormones shut off relative to before. We'll see very low estrogen, almost undetectable. Progesterone, usually lowish levels of testosterone and DHEA, and then we'll see a bunch of symptoms associated with those. So when we look at the patterns, we're looking at the neurovasomotor hormone deficiency, low E, low P, E2, P4. And again, this is loss of hormones related to, ovarian failure, which we call menopause. Next slide. So intervention here, HRT is definitely in this person's future if they want to, get back up to optimal, but it's not the only thing that needs to be done. Again, it's about the terrain, making sure the metabolism's okay, thyroid's okay, inflammation's okay. And then, once that's settled, then the hormone replacement can be better optimized for that person. All right, big takeaways. What are the takeaways here? Again, for men, men tend to try to chase testosterone because that's what we learn. Sometimes it works great and sometimes it backfires. So you need to look for the underlying causes. Cycling women, you don't just want to rush into birth control and just suppress the heck out of everything. So we look at the underlying causes, and likewise with postmenopausal. My recommendation for all postmenopausal women, if you don't have any risk factors, you're not too far out of menopause, is there's no replacement for those. I mean, there's no. The hormones, estrogen, progesterone, are very important. So it's very important to have those as part of somebody's life. And not just accept the, you're fine without your hormones sort of thing. That's not, I don't think that's appropriate in this day and age. But again, you need to also make sure that the terrain is also fixed. All right. Why is the hormone optimization, why is it high leverage? Well, first of all, let's talk about the high risk. Just like if a guy takes a testosterone shot, they feel better. That can mask some of the dysfunction like we talked about. People might get fooled into thinking that this short-term relief is the answer is the bee's knees. And then, of course, if you overcorrect, like we talked about with escalating doses and things like that, then you start introducing more issues into it. And then the high leverage is, just some for postmenopausal women, especially, just a little bit of hormones can go a long way to quality of life, bone health, heart health, all the sorts of things we'll talk more about in the full module. All right, let's talk about what this module is and what it's not. First of all, what's not? It's not a dosing manual. I don't prescribe anything through this course. I will give resources on where patients can go or where students can go to learn more about various different resources that are out there, testing, interventions, things like that, but it won't be part of the program itself. And of course, it's not a substitute for individualized medical care. Everybody needs to make sure that they're under the care of a doctor that they know and they trust. So what is this module? It's guidance, education, helps people understand, helps students understand the foundation for longer term decision making, and helps them make better decisions on better interventions with the goal of optimization. Where do hormones fit into it? I think hormones, one of the more central drivers of aging. Again, a lot of parallels with metabolic health, sleep and circadian, physical functioning, immune balance, probably more. These are just some of the areas that I know of, and there's probably other drivers where it reaches across. Again, nothing's in isolation here. The human body doesn't work in isolation. Why this can change trajectory? Aging is not just about how you feel today. It's not about take this medication, take this replacement, feeling good to go. It's about trying to change the trajectory, trying to make sure things are optimized to give you the maximum health span, to allow our students to be in the maximum health space, for as many years as possible, be as resilient as possible for as many years as possible. That's the goal. Making aging optional is the mantra. All right, the final slide here. So what's inside the full module? Where does this go? I've already spoke in depth about what you'll expect in the full module. So where this goes next is, again, you can either, at this point, you can either choose to jump into the full module. We do hold a webinar that talks about the full framework, all the 7 drivers and more. Or you can just simply follow us on social media, on our newsletter to learn more about this. And we hope you found this useful. And I really enjoyed providing this information to you, and I hope you found it useful. Thank you very much.